Hello, everyone. Thank you for having me. I'm here to give you a 10-minute overview of what's new in AIH-PSC. There's really been a lot of ongoing research in this past year, and I've chosen to highlight a few articles that will further our understanding of pediatric autoimmune liver disease. I have no disclosures. The outline for today's talk will highlight practice guidelines for AIH. We'll discuss studies on newly proposed therapeutic options. We'll discuss the use of biomarkers and prognostic tools in autoimmune liver disease, and touch on the therapeutic controversy in PSC. This is the start of a great conference, so this talk will highlight some of the newest articles, but these will be further explored and detailed in coming talks. First, we'll touch on the new 2019 guidelines for AIH by the ASLD. I wanted to highlight Table 2 that describes the different definitions we use to classify an AIH patient, most importantly describing treatment failure, incomplete response, relapse, and treatment intolerance. Establishing these definitions allows for unified categorization of patients and how we manage them clinically and use in research studies. They also include an algorithm for clinicians to follow for a patient suspected with AIH, including serology and liver biopsy that will lead to the diagnosis of AIH, PSC, overlap, or another disease. They also include a diagram for the first-line treatment of AIH, categorizing these patients by those with AIH, AIH with cirrhosis, and acute severe AIH. They discuss the timing of assessing response, biochemical remission, and consideration for second-line drugs for patients. Families are always interested in decreasing immunosuppression or withdrawal of immunosuppression, and this table helps us understand how we could do that for patients. What they do highlight is that those with acute severe AIH, these patients should not have immunosuppression withdrawal, given their increased risk for relapse and failure off of immunosuppression. One of the hardest clinical scenarios to care for in AIH patients is what to do when your regular standard of care therapy is not working. There's a lot of focus currently on looking at second and third line agents, and this is a paper from the European group highlighting this. They include a table, again, with different medications proposed for third-line treatment or therapy for these patients, highlighting that tacrolimus is the treatment of choice, and this is something that we're seeing used more clinically, with patients becoming more comfortable taking. They also highlight the role of anti-TNF and mTOR inhibitors, with a lot of discussion now related to the use of mTOR inhibitors, examples of everolimus and sirolimus in this patient population. Now, what else is being studied? Focusing on other therapeutic implications, this paper explored the use of IL-2 in autoimmune hepatitis. It proposed that cyclical injections of IL-2 in autoimmune diseases, with autoimmune liver disease being one, demonstrated increased numbers of circulating regulatory T cells, preserved regulatory function, improved clinical manifestations, and excellent tolerance. They mention that low-dose regimens and preliminary studies encourage further investigation of this in autoimmune hepatitis. This is a paper from Huang et al. In China. So in recent years, microRNAs have emerged as crucial components in the diagnosis and therapeutic applications for various autoimmune diseases, in that they participate in disease development. Now, microRNAs are types of non-coding RNAs that function mainly as regulators in numerous physiological and pathological processes. This study explored this and showed that there was elevated serum mRNA 21 and 122 levels in AIH patients and decreased mRNA 200 levels in PSC patients, indicating their diagnostic utility for use in autoimmune hepatitis. Characteristic of autoimmune hepatitis, like other autoimmune diseases, is the accumulation of autoantibodies produced by B lymphocytes following their interaction with CD4 T lymphocytes. This study out of France looked at integrative molecular profiling of CD4 T cells in autoimmune hepatitis, highlighting that PD-1 and CD38 co-expression by T cells reflected disease activity. Now, this is an example of work that will be essential to track, delineate, and target pathogenic T cells in AIH. Understanding the gut-liver axis continues to be important in involving in autoimmune liver disease. This study looked at alterations of gut microbiome in autoimmune hepatitis, and they showed that the steroid-naive AIH microbiome was associated with remarkably reduced bacterial diversity, and that the enrichment of Leionella dispar in the gut was linked to disease severity. Next, we'll talk about biomarkers, really exciting and new to the field. This is a great study out of Cincinnati Children's that looked at serum MMP7 as a biomarker for pediatric sclerosing cholangitis. This included all patients with pediatric autoimmune liver disease, so those with autoimmune hepatitis, PSC, and overlap. Here they were able to show that the serum MMP7 level greater than 23.7 was sensitive and specific to those with sclerosing cholangitis compared to those without cholangiopathy, and that this outperformed GGT and ALK-Phos. They were able to show that serum MMP7 was a biomarker for all types of biliary injury, irrespective of extrahepatic or intrahepatic location and large or small duct disease. Additionally, they highlighted that serum MMP7 correlated with increased number of dilatations, strictures, and increased liver stiffness. This study looked at the biliary immune landscape. So they took endoscopy-guided samples of bile fluid in the biliary tree and comprehensively mapped this, looking at the human biliary immunological landscape for patients with PSC. And what they showed was that there was major differences in the immune cell composition in bile ducts compared to blood, and that biliary inflammation in patients with PSC was characterized by higher presence of neutrophils and T cells as compared to controls without PSC, and that biliary resident T cells from patients with PSC co-express receptors for gut and liver homing. Now, trying to understand which patient is at higher risk for complications leads us to implementing prognostic tools into practice as we care for patients. The first we'll discuss is the SCOPE index that looks to predict liver-related outcomes for children and adolescents in PSC. This helps stratify patients into low, medium, and high risk, with figure A showing that the highest risk group, that in purple, was the least likely to be able to go 5 years out of diagnosis of PSC without a liver transplant. And figure B, they show that those with the highest SCOPE index really had the most fibrosis, so F3, F4 fibrosis. So what does the SCOPE index mean for future complications? This table shows probability based on risk group for the development of hepatobiliary complications or transplant or death in 5 years from diagnosis, with really the highest risk group having these complications even within the first year. Overall, the SCOPE index is a valuable tool and is becoming more and more used in clinical care. This is another prognostic tool that was out this year. This is called the PRESS2 prediction model with an endpoint of hepatic decompensation. This includes 9 variables, with really total bilirubin and albumin taking the most weight into the equation. This included patients with cholangiographic evidence of PSC, but what was not included is pediatric patients, so age less than 18, those with small duct or overlap, cholangiocarcinoma, or the sicker end-stage liver disease patient. The rationale for this approach was that the development of this tool would be applied in the context of clinical trials, with sicker patients not being eligible. The performance of the PRESS2 accurately predicted hepatic decompensation in PSC and performed well when compared to the MELD and Mayo PSC risk score. Now, last we'll touch on the management of PSC. So there remains a lot of controversy, but further studies that we're going to discuss help us understand how we care for these patients and how further research is needed. First, we'll discuss this retrospective analysis that used the data from the PSC consortium. In this, they compared children on oral vancomycin to ursodiol to no treatment, so observation. Biggest results of this was that the favorable outcome was associated with a mild phenotype, a lower SCOPE index, and those with minimal hepatic fibrosis. By 12 months, GGT was similar in all groups, regardless of management strategy, as shown in figure A. And in figure B and C, they showed that median bilirubin and RP score were unchanged from initial values, regardless of management strategy. The conclusions of this study showed that there was no significance in outcomes between oral vancomycin, ursodiol, or no treatment with regards to GGT, liver fibrosis, and transplant listing. On the flip side, this is a published study from 2020 that showed the biochemical response to oral vancomycin for PSC patients, and they demonstrated median percent change in GGT, ALK-Phos, and ALT within 1 to 12 months from baseline. They further focused on comparing this for large duct versus small duct, with the study showing that there was no statistically significant difference in chemistry responses between the two groups. Again, highlighted is that dosing, formulation, brand, clinically observed differences continue to be present, and further studies need to be undertaken to elaborate on the use of oral vancomycin in PSC. So in conclusion, ongoing studies are needed towards management of the difficult AIH patient. Further research is encouraged to understand the gut-liver axis in autoimmune liver disease. Serum MMP7 is shown to be a good diagnostic marker of biliary injury and fibrosis in pediatric autoimmune liver disease. Prognostic tools are emerging as helpful and should be considered to be implemented routinely into clinical practice. And a good therapeutic option for PSC remains, with further research needed. Thank you for your time.
Hello, everyone. I'd like to thank the sponsors for inviting me to give this talk. I'll be speaking about autoimmune liver disease, IBD, and the gut-liver axis. My name is Saeed Mohammad, and I'm an associate professor at Northwestern University. I have no financial relationships. So autoimmune liver disease includes autoimmune hepatitis and PSC, while IBD includes Crohn's disease, ulcerative colitis, and indeterminate colitis. We're going to talk a little bit about the natural history of PSC, PSC and IBD, the gut microbiota and PSC, and finally, potential therapies. Over the last 2 decades, there's increasing interest in the relationship between the gut microbiome and other organ systems. The association of autoimmune liver diseases and IBD has been known for over 60 years. The gut microbiota in metabolic and inflammatory diseases show significant deviations from the healthy state. This was a study done in Utah by Mark Deneau. He collected 600 patients with IBD and looked to see how many had PSC and how many with autoimmune hepatitis. You can see that the majority of the patients with PSC also had IBD, while the overlap between autoimmune hepatitis was not as strong. This was the largest study that was a multi-center international collaboration with 781 patients who had pediatric onset PSC. The median age was 12 years and 39% were female. 3/4 had IBD, with the majority having ulcerative colitis, while the rest had Crohn's disease. Large duct involvement was present in 87%, and overlap with autoimmune hepatitis was present in about 1/3. Now, small duct PSC and PSC IBD had milder phenotypes. PSC autoimmune hepatitis had similar adverse outcomes compared to PSC patients alone. And this survival data suggests that the degree of cholangiopathy is what determines long-term outcomes. When we're looking at PSC IBD subtypes, it has distinct clinical features such as pancolitis, backwash ileitis, rectal sparing, and subclinical inflammation with an increased potential for malignant transformation. PSC IBD patients typically have milder intestinal disease compared to IBD patients alone, with more extensive colitis, while PSC Crohn's disease patients have more colonic involvement, followed by ileocolonic involvement. There's a lower frequency of stricturing and penetrating disease, and the intestinal inflammation is usually quiescent, leading to milder symptoms. Now, this graphic just shows some of the hypotheses between how patients with IBD may also have PSC. There's a gut lymphocyte homing hypothesis. So there's shared chemokines and adhesion molecules between the gut and the liver, and activated lymphocytes from the inflamed gut may be transported to the liver through the portal vein and cause inflammation. There's the leaky gut hypothesis that suggests that increased intestinal permeability causes translocation of bacterial metabolites from the inflamed gut to the liver. There is also a genetic predisposition, but this is still very weak. And then a bile acid microbiome interaction from the bile acids that are excreted by the liver into the intestine. Looking at autoimmune hepatitis and IBD, several studies report more refractory hepatic disease and IBD symptoms that are less severe. Many patients who have IBD are on anti-TNF medications, and this study out of sick kids looked at those patients, over 600 of them, and 7.7% had LFT derangements. 6 had biopsies, and out of these, 3 had PSC, while the suspected 4th may have had it. And in all cases, medication was stopped and the labs resolved. This is shown here in this figure. You can see on the left that 46 ALT elevations were explained, and most of those were either due to an IBD flare or antibiotics or due to other medications, while only 3 patients had PSC and 5 had NAFLD. 43 out of 46 ALT elevations resolved, and 40 of those patients remained on anti-TNF while 3 had to stop. On the right side, you can see that 9 of the ALT elevations were undefined, and 8 of these resolved on their own. Now, the gut microbiota in PSC, it differs in patients with PSC compared to PSC and IBD and healthy controls. The gut microbial diversity appears reduced in PSC. The genus and species level findings are mostly inconsistent between studies, but this can still hopefully be used as a biomarker in the future. The loss of microbial diversity may be pathogenic and originate from dietary alterations and specific environmental changes. The loss of microbial diversity observed PSC may play a causal role in disease development by mechanisms that remain to be established. Now, this has been shown in patients with type 1 diabetes. The loss of microbial diversity precedes the diagnosis and is associated with autoantibody positivity. Looking at gut permeability and bacterial translocation, damage to the enterocytes, which are the intestinal cells, can be caused by dysbiosis of the microbiome and can be caused by inflammation, infections, or antibiotic usage. An impaired gut barrier allows microbes and pathogen-associated molecular patterns to pass and reach the liver, and causing inflammation through receptors on Kupffer cells, liver sinusoidal endothelial cells, and hepatic stellate cells. This is shown here in this graph. If you look starting at the bottom right, you have dysbiosis, which causes gut barrier damage, leading to bacterial translocation, going through the portal vein into the liver, and affecting the liver cells there, causing inflammation, fibrosis, and cirrhosis. The liver itself produces primary bile acids, which are interacted with the gut microbiome. After a transplant in a patient who's had PSC, there's reports of worsening colitis. De novo IBD has also been reported. There's usually less histologic severity of IBD after transplant, and always concern for PSC recurrence post-transplant with an intact colon. Colectomy may be beneficial in a subset of patients with IBD. So we've talked about the natural history of PSC and IBD, the gut microbiota and PSC, and now we'll talk a little bit about potential therapies. So one area to target is the gut microbiome using prebiotics, probiotics, antibiotics such as rifaximin, nutrition, and FMT. So the most common antibiotic that we generally use is rifaximin, which leads to reduced endotoxemia and modulates the gut microbiome. FMT, or fecal microbiome transplantation, has been shown to reduce damage in mice in those with alcoholic liver disease, and high-fat intake in mice leads to gut dysbiosis and reduction of butyrate-producing microbes in favor of the formation of LPS through gram-negative bacteria, which leads to increased inflammation. So these are all targets that can be used to improve outcomes in PSC. Here you can see in this graph again on the bottom right, looking at the intestine, you have FXR agonists, antibiotics, prebiotics, and nutrition. And on the liver side, you have some medications such as ursodeoxycholic acid and FXR agonists and fibrates. So in summary, most patients with PSC also have IBD, usually ulcerative colitis with distinct features. Autoimmune hepatitis and IBD occur less commonly, and the gut microbiota is different in patients who have PSC compared to those with PSC IBD versus IBD. And bile acids, chemokines, and bacterial metabolites may all play a role. Thank you.
Hi, everybody. I'm Emily Perito. I'm one of the pediatric hepatologists at the University of California, San Francisco. I'm really sorry that I can't be there in person with you today, but I really appreciate the opportunity to share with you virtually, and I look forward to talking to more folks during the meeting. I'm going to talk today about medical care for autoimmune liver disease and chronic liver disease in the age of COVID. Isn't this over yet? And unfortunately, as you guys know, it's not over yet, but we have come a long way. So really important to still be thinking about. Here are my disclosures and some additional disclosures. Please keep in mind about COVID, that the knowledge about COVID is constantly evolving. So I tried to provide as up-to-date information as possible as I could to you today. No single answer or strategy applies to every child or young person with autoimmune liver disease, but I'm going to try to share sort of general principles today that I think are generally applicable to most people. And please discuss you or your child's specific situation with your own team of medical providers. They know you best, they can offer the most personalized advice. And we're all, we've all answered a lot of these questions for a long time now, so we're happy to talk to you about it. Since COVID is unfortunately not over yet, I thought we could talk about 3 questions today. The first, are young people with autoimmune liver disease or chronic liver disease at higher risk for COVID infection or for severe illness or hospitalization from COVID infection? Number 2, should people with autoimmune liver disease or chronic liver disease get the COVID vaccine? What are the risks and the benefits? And number 3, how can young people with autoimmune liver disease stay safe at school and in other group settings? I imagine many of you have already ventured back into that in the last few weeks, but are still thinking about how to do this safely and how to keep things going. So we'll try to talk a little bit about that as well. First, what do we know about COVID infections in people with autoimmune liver disease or chronic liver disease? Now, you guys know very well that autoimmune liver disease in young people is relatively rare. And so there's not a lot of data, but I think we can extrapolate reasonably from both adult data from autoimmune liver disease in particular, and then some data on children with liver disease more generally. In adults with autoimmune hepatitis, there's reasonable evidence that there's no increased risk of ICU admission, no increased risk of death compared to adults without liver disease. There may be a higher rate of hospitalization that's been shown in at least one study, but it's hard to tell if this is related to more severe infections or if this is related to a lower threshold for hospitalizing these patients because there's a concern that they may get sicker. Adults with autoimmune hepatitis also do not appear to have worse outcomes than others with chronic liver disease. And actually, adults with autoimmune hepatitis who get COVID infections seem to have less severe liver injury, less elevation of their liver enzymes when their immunosuppression is continued. Now, again, that may be a little bit confounded. If there's a mild infection, then patients are more likely to continue their immunosuppression. Because of the mild infection, they may have less severe liver injury. However, it at least says that immunosuppression doesn't necessarily have to be stopped for every COVID infection, and I'll talk a little bit more about that later on. In adults with PSC, unfortunately, there's not really dedicated studies to look at this. The primary sclerosing cholangitis patients who in the adult series are really combined with the other chronic liver disease patients. And what we know about adults with chronic liver disease in general with COVID infections is that, again, they're not necessarily likely to get sicker than other adults, except for those patients that really have end-stage liver disease or cirrhosis, and then they're at risk of more decompensation from their liver disease than more severe COVID infection per se. In children and teenagers, we have a pretty limited amount of information. There is a very nice case series that was sort of contributed to by folks across the world of COVID infections that presented in kids either with liver disease or liver transplant. And they found no evidence for an increased risk of severe COVID infection in kids after liver transplant or kids who were on immunosuppression. There was a handful of kids in that series that had autoimmune hepatitis and were on immunosuppression. And again, no evidence of more severe infection or hospitalization and no deaths in that series. So should people with autoimmune liver disease or chronic liver disease get the COVID vaccine? I'm sure you heard this before, but generally the answer is yes. The COVID vaccines, which are mRNA vaccines, are non-live vaccines. They cannot cause COVID infections, even in immunosuppressed patients. They're currently approved for children aged 12 years and older in the US, and there are extremely few contraindications to getting the COVID vaccine. So generally the recommendation is yes, please get the COVID vaccine. The vaccine is highly effective for preventing severe disease and hospitalization. A little bit more information about sort of the risks and benefits and how to think about that. We know that COVID infection commonly causes elevated liver enzymes, plus it can cause severe disease in children in very rare cases. It also, as we know, causes more missed school, more missed sports, more missed social events. And we know that kids are very excited to be back to that. And I'm sure as you all as their families or providers are excited to have them back to that too. So I think, COVID infections continue to be really a big disruptor to people's lives and are better to avoid if we can. We are seeing increased COVID infection rates across the country in many communities with the Delta variant, also with less lockdown and people sort of going back to their lives. So this means that COVID is still out there. It's not over and you can still get it. So the vaccine is still really important for preventing that. Finally, there's no evidence that the COVID vaccine triggers autoimmune liver disease or causes flares in patients that already have autoimmune liver disease. And I'll talk about that a little bit more specifically next. So does the COVID-19 vaccine cause autoimmune liver disease? Could it cause a disease flare? There have been several case reports. I found 6 in the literature of autoimmune hepatitis developing after the COVID vaccine. This was all in adults. These were all patients all treated with prednisone who all resolved. There's not very long-term follow-up, but they seem at least to come out of their initial flare. And this may not be something that comes back in them. Now, to put that in perspective, we have to think about sort of how many people develop autoimmune hepatitis in the US, even in the absence of the COVID vaccine. And are these 6 case reports really related to the COVID vaccine or just coincidental? Now, in the US, we expect an incidence, so a new onset autoimmune hepatitis cases in about 1 of every 100,000 people. And in the US, we've vaccinated at least 13 million people so far since the vaccines became available. So we would expect from that even about 10 coincidental cases of autoimmune hepatitis, where people develop autoimmune hepatitis and they just had the COVID vaccine, but those things aren't actually related. So I think that there's no good evidence to date that COVID vaccine causes autoimmune hepatitis, that it causes flares in autoimmune liver disease, or that it worsens chronic liver disease more generally. And again, we know that COVID infection can cause elevation in liver enzymes. And so I think that's the risk-benefit balance it's important to think about. Who's currently eligible for a third vaccine dose? So this is new from the CDC over the last few weeks. You may have heard about it already. Children 12 years and older who are eligible for the first 2 doses are also eligible for the third dose. If they have a liver transplant or other solid organ transplant and are on immunosuppression. If they're on what's classified as high dose steroids, that means prednisone of 20 milligrams daily or higher. If they are on anti-metabolite immunosuppression, that means mycophenolate, which is also known as Cellcept or Myfortic. If they are on TNF blockers, this includes infliximab, which is Remicade, or other biologic agents. Now, these are not usually used for autoimmune hepatitis, but if you have PSC and you also have inflammatory bowel disease, you may be on one of these agents. And then in terms of other medications that are used for immunosuppression, like azathioprine or tacrolimus or others, they're not specifically mentioned in the CDC guidance, but the answer is probably you should still get a third vaccine dose. The benefits outweigh the risks, but you should ask your medical team. Now, this was really driven entirely by adult data, mostly from the transplant population, showing that there is a response to the vaccine in these patients, but it's less robust than in other patients, and that a booster vaccine seems to increase antibody response and increase antibody levels. We do have some data forthcoming on a small number of pediatrics, so teenagers with transplants that have gotten the vaccines, and it looks actually more promising in terms of response than in the adult transplant recipients. That data is not out yet, but hopefully will be in the next couple months. However, you should still go ahead and get a third vaccine dose if you are eligible. It's, again, very, 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 very unlikely to hurt and may help protect you. So finally, I want to talk a little bit about how young people with autoimmune liver disease can stay safe at school and elsewhere. There's no new magic messages in this. These are the things that you guys have been hearing, and I'm sure telling your kids over and over again for the last several months. When we're thinking about how to advise people on this, we tend to think about it in sort of 3 buckets. What's going on with your child? What are they capable of and what works for them? What's happening at your school? What kind of policies and procedures do they have in place to protect your child and other children? And then what's going on in your community? What are the rates like in your community? How much COVID is just circulating in the community? Masking is still the most important thing you can do. Indoors with anyone who lives outside of your household, this is the best way that particularly kids can protect themselves against getting COVID. Really important to ask about what's going on in the school. Really encouraged to wear masks at school if your child is able to do that, and if others around them are able to do that. Another really important thing is staying home if you feel sick. We know the most important predictor of COVID in kids is whether they've been exposed to someone else who has COVID. And so, making sure that you are keeping distance from folks that do have symptoms of illness remains very important. So what about immunosuppression? What should we do with that to prevent COVID or if we get a COVID infection? These are just a summary of current expert consensus guidelines. Again, this is based mostly on direct data from adults in both the US and Europe, but I think is reasonable to apply to kids as well. The first piece of advice is please don't change immunosuppression in somebody with autoimmune hepatitis who has had a transplant or who has had a transplant who do not have a COVID infection or who have a mild infection. Mild infection generally means that you don't need to be hospitalized. They're able to be monitored at home. It's actually sort of reasonable to continue your immunosuppression in either of those cases. In patients with moderate to severe COVID infection, so that's COVID infection where you're hospitalized because your symptoms are significant enough, many adults and some pediatricians will consider decreasing the mycophenolate. Again, that's Cellcept or Myfortic. In adults in particular, the anti-metabolites seem to be associated with both COVID severity as well as decreased antibody response. But again, if you do not have a COVID infection, do not change your dose. And then generally folks are trying to minimize chronic prednisone exposure in patients without infection. But not necessarily stopping or changing steroids for a COVID infection. And then again, just please do not change or stop your immunosuppression without discussing with your liver team. So in conclusion, a few take-home points. COVID-19 is not over yet, but we do have a lot more control over disease transmission and severity than we did before, both at the individual and the community level. Everyone eligible should get vaccinated as soon as possible. Getting vaccinated is much safer than getting the COVID infection. Most young people with autoimmune liver disease or chronic liver disease can attend in-person school, and masks still work and are especially important in group settings, indoors, like school, or other things you may be doing indoors with people outside of your household. Thanks for the opportunity to share with you today, and I think we'll have a chance for discussion later, or you're welcome to send me a message with any questions.